Dental professionals, listen up because we're about to share a game changer for periodontal care. Imagine a product that makes debridement faster, easier, and more effective. Sounds like gold, right? Introducing PerioDT, the topical dental debridement medicament that desiccates biofilm in seconds, quickly and efficiently removing the smear layer and necrotic material from tooth surfaces. Clinicians are raving about how it saves time, reduces hand fatigue, and boosts patient outcomes. With its fast acting desiccation technology, PerioDT removes debris and supports periodontal and implant maintenance, all without antibiotics. It's safe for use on dentin, enamel, and even titanium. Available as a liquid or gel, just one 1 milliliter syringe treats a full arch. Quick, easy, and effective. Join the professionals who call PerioDT a must have for periodontal therapy. Visit yng.inc/hygiene elevated to learn more today. Hey guys, welcome back to Hygiene Elevated Conversations and Innovation. We are super excited today to be partnering with Young Dental to talk about their product, PerioDT. And we're really excited to have Shelley Brown back on the podcast with us today to give us some information about this wonderful new product. So, Shelley Brown is a dedicated dental educator, speaker, and mobile clinician, and she's passionate about making dentistry more accessible and innovative. And she's going to really deep dive into what PerioDT is and why we should all be using it. So, welcome, Shelley.
Thank you so much. I'm happy to be back on the Hygiene Elevated podcast, especially talking about this product because it is one that I love.
Yeah, I can say that I've heard a little bit about this and I've always wanted to learn more and to use it myself. So, I'm excited for you to give me like the full spectrum of information so that I can understand it better to use it in my practice. And I'm sure all of our listeners feel the same. And even those who might be using it might learn a little something new today. So, let's go ahead and start off with, can you introduce PerioDT to us? Share with us why you're using it in your mobile practice and what it is.
Yes, I sure can. So, to start off with, I learned about this product at the Mobile and Teledentistry Conference about 3 years ago. And when I first heard about it, I was like, there's no way because you're making it sound so amazing. That's too amazing. That's like too good. But let me tell you, all the things that it does are absolutely amazing for our practices for periodontal therapy and as an adjunct to periodontal therapy. So, essentially, just an overview, the biggest thing that it does is it dehydrates or desiccates biofilm. So, it's hygroscopic, which means that it absorbs water. And if we remember, clear back to, I don't know, our perio classes, biofilm is like 95% water. So, if we take the water out, then we destroy the biofilm. And as we know, biofilm is the leading cause of our periodontal diseases, periodontitis, gingivitis. So it's especially really great at working on our periopathogens, like our Porphyromonas gingivalis. Really amazing for that. There's a study we're going to link in the show notes, but it keeps that bacteria low for 365 days plus. They
Wow.
studied in this one study, which generally, we're bringing patients back for periodontal maintenance every 3 months to disrupt biofilms that our patients cannot reach. So if we can disrupt those biofilms before and keep them low over time, I'm still keeping my patients on short recalls, but it will help them reduce their systemic and oral inflammation. Also, just to mention, it is FDA cleared as a medical device. Everybody always asks that, and it is used we're gonna talk more about how it's used in hygiene, but it is also used in caries restoration because it removes a smear layer. We'll talk about that a little bit later. Also root canals, because in root canals, we're trying to get rid of all the biofilm, bacteria down in there. So dentists are using it for those therapies as well. But we're gonna focus more on our periodontal therapies because that's where our expertise lies, right?
Yeah, absolutely.
Absolutely. Okay, Shelley. So I'm trying to gather who's the ideal patient for the perio DT. I'm guessing our gingivitis perio patients, but tell us exactly who is the right candidate for this.
Yeah, you hit the nail on the head there. Our patients who have gingivitis, periodontitis. So it's not to be used in health to desiccate biofilm. So mostly in those situations. Also, if you have an implant that you see has mucositis, if you see any exudate, those types of issues. Obviously, I'm using it in my mobile practice because my patients, they literally do not get their teeth brushed well. And so I need ways to keep the biofilm low for longer periods of time between when I can get there. And but for private practice, anybody who does not have great biofilm control at home and they have any inflammation, this should be placed on them.
Gotcha. That is so cool. I'm intrigued. I'm ready. Um,
Mhm.
so what are the ingredients to this? Is it a gel? Is it a liquid? When do we use one over the other if there's both? And what makes this do what it does?
Yeah, so the ingredients that it contains is 60% sulfonated phenolics. So that's like the main ingredient. 28% sulfuric acid, 12% water. And those first two ingredients, you're thinking, I heard the word acid and something about sulfonated, something or another. So some people get a little bit worried like, what is the pH of this thing? It is below the pH of orange juice, even below the pH of yogurt. So I don't want you to be thinking, this is going to be causing like caries to my patients. All right. That's not going to be a concern. But essentially, what it does is it creates like an electrostatic charge to attract water from the pathogens within inflammation. If we think back to like dental materials, those van der Waal forces, it works through that chemically. And then once it's dehydrated, the biofilm actually detaches from the root surface, a flaky little pastry lifts up off of the root surface, which is interesting. And then it's easy to remove after that. It's not as adhered. And then you asked a little bit about the gel versus the liquid. So it does come, PerioDT does come in a gel and a liquid. And when do we use one over another? So personally, I like to use the gel when I just need it to be like more on the, maybe I don't have as deep of pockets. Maybe I have more of a gingivitis condition. So I don't need it to flow into a deep pocket. And I like the gel because then it doesn't get everywhere. So we really want to keep it contained only to the areas we are working. It's not like a irrigation where we put it in and it could just flow out and get all over in the mouth, no big deal, right? We want to contain this just to that one localized area only, mainly because it can turn other areas of the mouth a little bit white with its dehydration action. And that might look a little concerning to the patient. So it's really important. We're going to talk about the steps to place it, but to keep it really in one area. So I do like the gel when I'm trying to contain it. But if I have a deeper pocket on an implant or just on a tooth and I need it to flow deep and get it into those areas where maybe my ultrasonic can't reach as well, into the nooks and crannies and root surfaces, I like the liquid. So it's great to have both in your pocket, in your drawer, and you might want to use one over another.
This is amazing. Shelley, I am having like this feeling of all these patients and their faces are like popping in my face of who needs this. Like I can already see this very cute elderly gentleman who has just terrible dexterity issues. So the biofilm accumulates every single time I saw this gentleman. And he's just one and I just mentioned him because he's just a little sweetheart in my heart, but there are so many. There are so many patients that popped in my mind immediately that could be a good candidate for this. So I'm very excited to learning about all this. I've been taking a bunch of notes over here, Shelley.
Awesome. I think too, as you're visiting that patient, think of yourself as a clinician, like you have maybe these deep pockets you're trying to access. And we're using our hand instruments, which don't remove biofilm really well. They're great at calculus, but biofilm is like all over the root surface. And it is actually really hard to get every nook and cranny and tiny piece of biofilm off, even with our hand instruments and the ultrasonic. Like it's hard to get every square millimeter. So anything that potentially we leave, even though we know we're perfect, this can go in and help get for those patients and access.
Gotcha. I do have a question. You mentioned being able to use this for implants.
Mhm.
Now, again, we have people popping in our mind. So when you're looking at like implants or periimplantitis, is there a specific measurement of like bone loss that you know that you're trying to hold on to the implant, but the prognosis is poor? Would you still use that on those kinds of implants, or what condition of implant would you use that on?
Yeah, great question. Obviously, collaborating with the dentist, if they're like, it's mobile, it's PerioDT is not going to work, right? But if we're getting early stages, maybe you see some suppuration and the bone is disintegrating, and you're like, what do we do? Then yeah, this might be a really great option to try in those areas. Maybe it's just a biofilm condition. Now, if it's a condition of there's floss that's harbored down around those areas or extra cement from the implant or plastics of some sort, then that if this is not going to be able to dissolve those. But if it's a biofilm issue, 100%, this would be a really great option for patients.
So I'm curious, Shelley. I know we've identified who the ideal patients are for this product, but in terms of applying it into your appointment sequence, is this something you apply after you've done scaling and root planing, or is it something that you would do before? Like, where does this fall in the line of order of operations for you?
Great question. The workflow, right? What is recommended based on the studies is that we place it first, then we instrument, and then we place it again. Well, let's talk about placement for just a second. When we place it, very important you place the barriers on a cotton roll, whatever works best for you. Then you're going to dry the area like super thoroughly. The reason why you'd want to dry it really is because when it hits water, it works. It like sucks the water up and then it deactivates, you could say. And so if there's saliva on the surface before you get to the biofilm, it's going to work on that first. And so that's another reason why to place it again, just in case like an area wasn't fully desiccated. So dry it really well. You're going to place it. It goes on just like a gingival irrigation almost. That's pretty viscous, right? But you just place it in the pocket. Just we've all learned how to do that. Just flow it right into the pocket area. Within 10 to 30 seconds, it then needs to be removed. You don't want it to stay and linger in the pocket. So how you remove it first is you high volume suction it off so that it doesn't fly everywhere when you go to rinse it off. It does have a little bit of a taste, so that's also to keep that taste down, as well as we just don't want the medicament going other places. And then you can, once you high volume suction it off, then you can rinse. Then you'll instrument, and then at the end, you reapply it the same way.
Very similar to etch.
Yeah, I would say it's the same viscosity of an etch on a for a sealant type thing, but you're placing it in the gums.
Okay, awesome. So we place it in the gum. So walk us through how PerioDT then works and what is the primary benefit when we're trying to manage periodontal disease?
Yeah, I love this question. There are many things that it does, so stay tuned with me while we go through each one here. Because I called it to a friend, I was like, "It's like the Windex for Perio." Have you seen that show, The My Big Fat Greek Wedding, where he sprays Windex on everything? He's like, cures all. I'm like, "Dang, this stuff has a lot of benefits," is what I'm really trying to say for our patients who have periodontitis or gingivitis, periodontal diseases. The first thing we talked about first was our biofilm removal, right? That it dehydrates that. The second thing that it does and why some use it in like dental world is it removes the smear layer. Now, I just recently learned about the smear layer within the last year and I was trying to look at it in my I was like, where does it talk about this in my like Perio 1 textbook? Cuz I teach the Perio 1 class and I'm like, it doesn't talk about it. But I was reading as I was studying more and more about this product that it removes a smear layer on the root surface. So when we instrument, there is a smear layer after we're done instrumenting all over the root surface. And what even is it? It's cementum, it's calculus, it's biofilm, it's tissue that's just all over the surface. And there are studies that show that when we leave the smear layer on the root surface, we don't get attachment back of those gingival fibers to let the junctional epithelium or periodontal ligaments potentially readhere back into that cementum. So I've been leaving the smear layer on for my whole career, right? I have done nothing to really remove the smear layer. Nobody's taught me how to remove a smear layer. And this product removes that smear layer. Reminder at the pH of orange juice, very low pH. It dissolves that smear layer, opens up that surface so then we can get reattachment. And that's why the studies show that it works to help gain back more junctional epithelium and decrease those pocket depths. So that's the first thing that it does. It does more, but if you guys have questions on the smear layer, we can ask about those, but we have some more to get to.
Reattachment? Are you kidding me? Keep going, Shelley. I am hooked.
Okay, so it helps to do that. So that's like the first cool thing that it does. They studied a few other products. There was one study we'll link in the show notes that talked about sodium hypochlorite and a nano silver to see if it removed the smear layer. And this one does it better. So that's exciting. Okay, the next thing it does hemostasis. Have any of you been working in so much blood and you're just like, I'm going, but I cannot see? I'm all feel, right? Or you're rinsing constantly because there's so much bleeding. It reduces bleeding. So that's really exciting. It does that essentially as it dehydrates the tissue. It almost like sucks up all of the inflammation. And so with that tissue titer and the medicament, it reduces the hemostasis. So if you're having lots of bleeding, maybe you have a patient who is on like blood thinners, this might be a really great option. It's also reported to soften calculus. And I just say reported because they haven't done a study on like it softens calculus like this percentage of the time. But because it has that lifting effect of the biofilm and calculus is made of biofilm, if you have a really tenacious piece, put some of this on there, let it sit in for the 10 to 30 seconds, go at it again, and it will help remove that calculus easier. The next thing that it does, which I think is really cool, is it reduces our inflammatory mediators. So there's a study we'll link in the show notes that talks about the inflammatory mediators before and after. One of our goals of periodontal therapy is to remove the biofilm, of course, and that tells the body, okay, the fight is over. We no longer need to be like working here. And because what happens with our inflammatory mediators, they go into the connective tissue and they create collateral damage of the periodontium. And with that collateral damage, that's why we get destruction. And so if our inflammatory mediators are still working hard in there, even though we've removed the biofilm, we might get continual destruction. If we can reduce the biofilm and the inflammatory mediators at the same time, then that reduces destruction of the periodontium. They did this study on the MMPs, specifically MMP8 for Perio, our interleukin 8B and 6 intertissue necrosis factor alpha. Those are like the big ones that are those inflammatory mediators that are causing the destruction. And it reduces those super low, almost negligible. So that's really exciting for patients and their healing process. That's why another reason that we get our pocket depths reduced in those studies. That's why we see that. And then the other one is that it soothes the gingival tissue and kind of cauterizes it. So when we think of, there used to be a time when they taught gingival curettage in schools. Were either of you taught that? Were either of you taught curettage?
It was like they used to do this kind of
Yeah.
a message.
Yeah. Yeah, so they used to do that where it was like you take the opposite end of your instrument and you roll it along the tissues and you get out all the necrotic tissue because it was full of biofilm and bacteria embedded into the tissues, essentially. And so what this does is it helps to cauterize that gingival layer because it's a wound, right? It's a wound down in that pocket. So it does help to soothe that gingiva. And then something you might be like a little wondering about, but I'm asking myself the same question these days is always asking about the commensal bacteria. Tell me what it does to the good, right? As hygienists, we're so worried about destroying the bad bacteria, but sometimes the good bacteria, they've done studies that if we give our patients good bacteria, then it can also help combat periodontal diseases and keep the bad boys down. So it does affect our commensal bacteria in the zone of placement. So not like the whole oral cavity. But our commensal bacteria, they're so smart, they know what to do. They'll regenerate within 24 hours. If you are concerned about this, you could definitely give a little commensal bacteria at the end of the appointment or make a recommendation for that for home care for your patients to help support in the healing process. We're finding more and more about like commensal bacteria and how it can help keep the the periodontal pathogens down low, but that might be one idea that you could seek for your practice. So, those are the main 6 things that it does.
That's a lot of things. And that's a lot of amazing things that we can see so much benefit for so many different patients in so many different stages of periodontal health. Those are all wonderful things, but talk to me. Are there contraindications and what are those?
There are. So if you have an allergy to sulfur, or if your patient has an allergy to sulfur, I should say, then this should not be used. And then they just haven't tested it on pregnant women and anyone who is a child. So pregnancy, contraindicated, and children. Any should be used on anybody 18 and over.
Okay, that's not a whole lot of contraindications. So that's
Yeah, so that
a
makes it
thing.
good, right?
Not
Yeah.
like the end of those commercials where it's, "Please know there will be side effects if you have a bajillion different things." So that kind of that really decreases our like, "Oh my gosh, can I use this? Can I not use this?" sort of a thing. So you pretty much have 3 things to watch out for. So that's pretty incredible. Are there any I know you had mentioned several times that there's some clinical studies, and we are gonna link those in our show notes. But can you talk a little bit more about some of those clinical studies and their how they're showing the efficacy of PerioDT?
Yeah, as you mentioned, we'll link him in the show notes. But the one that I wanted to mention was that they tested patients after 1 year and they used the desiccant with scaling and root planing. And it showed that there was a significant, I like that word, significant decrease in pocket depths compared to SRP alone. So in my mind, I'm thinking my goal is to decrease the pocket depths, right? And decrease that biofilm burden continually for this patient who probably has a very hard time already controlling biofilm. That's why we got here in the first place. And yeah, based on the research, if it's looking better over a long period of time, then I feel like that's something that we should highly consider for our practices.
I completely agree. And Shelly, one question that popped in my head a while back was you mentioned there was this very specific amount of time that we wanted to leave this on the what happens if the product stays in that area too long?
Yeah, that's a really great question. And nothing like bad is going to happen. As I mentioned to you, it works pretty quickly on the water and kind of, I don't know, you could say that it deactivates. That's the word that you could use. Obviously, you want to give a good rinse. And the reason why you don't wanna get it into other places is it does, as I mentioned, turn the tissues white. So this always is a little bit every time I place it, I'm always like, "Okay, this tissue is going to be extra." It looks like a pinkish white after you place it on, just because of that dehydration action. So it is very important to me that I get consent for that beforehand, because that doesn't, like, rehydrate for about 4 to 24 hours. It doesn't come back to the normal color. So if you've just used it on like the anterior teeth and your patient smiles and they're like, my gums look extra white, I don't want them to be thinking they burned my gums or something where it is not a burn. That I just want to be very clear that it is not that. It's just that dehydration action, taking out all of the inflammatory mediators, inflammation, essentially the water out of those tissues. And that's why it looks a little bit white. Another reason why we take it off quickly and just do high volume evacuation first is it does have a little bit of a acidic taste. It's how you mentioned etch, Nicole? You're like, "Is it's etch?" And you taste a little bit of that etch after they've rinsed it off if you ever had a sealant done before. You taste that a little bit in the back of your throat. It's like that. It's not like your patient, though, is going to I don't want you to get fearful of the taste. It's not like your patient's gonna be like, "I'm gonna throw up." They're not I've never had a patient be like, "Get that out of my mouth, never use it again." My patients all tolerate it just fine when I say, "It does have a little bit of an acidic taste." They're never like, "Don't" yeah, they're never really concerned about that. I just don't want clinicians to be like, "The taste is terrible."
Oh, thank you for
Everybody
clarifying because I was just thinking if we left it on too long, are we causing damage? Or are we
mm,
putting our patients at harm? I just wanted to totally understand why there was that time on there.
yeah. Yeah, mainly because it turns it white, the taste, and then if you get it on other areas, like if you spread like just go right into instrumentation and it like gets on the other mucosa, it might turn that white. And so the patient would be like, "There's white all over my mouth after this procedure. What the heck happened?" So mainly it's for that.
Okay, gotcha. Now that was really helpful. So you mentioned like having explaining this to patients and getting their consent about understanding that. Is this a type of product that you would have a separate consent form in the office for if you know that you're going to use it?
You could if you'd like to, but you can also just put it in your existing consent form for periodontal therapy. So if you're using like lasers or whatever product you might be using, you want those to be into your consent form. So just add it into that. You could definitely have a separate one, but I think if you're going to use it on every perio patient anyway, it's just great to put it in. And you could put like, you could draw a line through it if you don't end up using it that day or whatever it might be. But I would definitely still make sure that you put it in and patients are aware that this is an amazing thing that we're going to be doing extra for you today to help keep your biofilm low.
Okay, and on that same note, is there an insurance code for this?
The insurance code, you'll have to decide what's going to be best for your practice. There are some options that you can use, obviously. There is the D43A1, that's the antimicrobials. Usually that's like a per tooth code. So let's say you're like, I'm going to use it on this one implant area or this one area that has a deep pocket. You could do it per tooth if you'd like to. Or you could use the gingival irrigation code 4921. That one doesn't get as much coverage, like ever coverage, right? 4381, sometimes we can get some coverage on that from insurance, but 4921, the irrigation code, does I have never seen an insurance company reimburse that. Or just the 4999 code, an unspecified periodontal procedure with narrative, and then you would write about what it is. So the more we use these things in dentistry, the more likely or potential there is for them to have their own individual code someday. So yeah, based on your office, you'll have to decide what code is gonna be best for your patients.
I know that's like a whole other podcast. We can come up with a whole list of codes we need.
I
Right.
agree.
Oh, goodness. Okay, so I'm curious, Shelley, where can we order this? Is this on like just basically anywhere we're already ordering dental supplies?
Yeah, you can check with Young Innovations, and they can give you the access to where you can purchase this.
Okay, fantastic. I know we've got a QR to share with our friends who listen to the podcast as well.
So I do have another question because you mentioned it a little bit when we were talking about some of the other things. I know for a lot of periodontal therapies, there's a lot of different adjuncts that we can use in them. Is there anything such as laser or Reston or things like that? Is there anything that's contraindicated in that realm of things that if we're going to use PerioDT, we shouldn't use these things after? Or is there something that also marries the two and really amplifies their efficacy?
Yeah, so if you're going to use a topical anesthetic right afterwards, if you don't give in injections or maybe that patient doesn't want injections, you want to give a very thorough rinse. So place it and then rinse it again before you place any of your topical anesthetics because there is a potential risk for those chemicals to mix and we don't want that to happen. So really great extra rinses if you're going to use something like that. And then they just recommend waiting 72 hours after use if your office does recommend a Perio Protect tray or like a chlorhexidine rinse or yeah, mostly those are the 2. So they just want you to wait. I don't know the reason exactly why behind those. Maybe it's just to give the time for it to work and there's no inner reactions, but tell your patients to wait 72 hours afterwards on the chlorhexidine and Perio Protect like trays.
Okay. That's pretty cool. Thank you so much for kind of clarifying that because that's I would not have I'm one of those people with just the way my brain works is I don't read instructions very well. So anything auditory can always help me. I'll just be like, nah, okay, got it. So I think that's a really great and important thing for people to know that whether or not they're using that every once in a blue moon, I'll irrigate with chlorhexidine if it's like really severe. So that's good to know. So when we were talking about the insurance codes, dialing back to that, is there a way that we can market PerioDT within our practices for patients to be like, "Oh, okay, that sounds really great," and are there any suggested costs behind it?
Yeah, let's talk about cost for a moment. So this can be kept at shelf preservation, if that makes sense, like room temperature. It can also be kept for 2 years, and your office cost is anywhere from, like, 28 to $30, 28 to $38. It depends on how much you buy. And so offices are charging anywhere from just at cost up to $100. And if you educate your patients saying like this helps keep that bacteria that's causing this disease low for a longer period of time, then patients are on board. I have not had a patient who's been like, no, don't do it. You know what I mean? They're like, yeah. After I explain that this is a bacterial condition and we have to get rid of the bacteria, they're like, yeah, please do whatever you need in conjunction with that therapy, right? So that's usually how I'm marketing it to patients. I'm just saying this is what we have to do to get rid of the biofilm and bacteria. Patients, if they're gung ho, they could potentially have great home care and do that at home, but I don't really give them the option to not use it. I'm like, this is what we do. I wouldn't want to be like, I'm only not going to hand scale this one area because you don't want it. I just am like, this is my new policy and procedure, and just explain to them what that entails.
So would you be charging like say per so if it's like a gingivitis area and you're doing it generalized, as opposed to say doing SRP, you're on the left side and there's probably about 6 different sites that you're like that radiographic calc looks tense, let's put some down
Mhm.
there. How are you breaking this down per generalized versus localized?
Yeah, great question. One syringe will cover a full arch pre and post. And if you're doing the full mouth, you might end up using two syringes. But if it's more of a localized area and you're like, I don't need this everywhere, then maybe one syringe would do the full mouth. So it's really going to be dependent on what your patient's needs are and the severity of the condition. But in general, like one syringe should do about one arch pre and post placement.
This conversation is just so insightful because I'm thinking of how we can strengthen our relationships with our patients with products like these, how we can boost our own results on our SRP work and getting that attachment loss, those improving those probe depths, and then also like the opportunity to boost the productivity in the hygiene department. I'm just seeing like wins all over here. Like I'm really in love with this conversation, Shelley.
I know she's the queen of production, right? She loves to help her patients, but at the same time give them products that they need. And so this is a great way to do both of those in the practice. Help elevate the practice needs and if it, no finances, but also a really amazing product to be helping patients long term with their oral health, which affects their systemic health if we can reduce that inflammation. So important.
Absolutely. So, where do you see the future of periodontal care heading with products like PerioDT kind of paving the way for easier and better ways to care for our periodontal patients? Where do you see us going?
Mhm. So this is an adjunct, right? It's not going to replace our therapy, our hand instrumentation, our ultrasonic use. So keep that in mind. That's very important to still do. If you have a laser, continue to use it in addition with your laser during treatment. Same with air powder polishers. It's just going to make it so we can be better at our jobs and do better for our patients, right? So that's where I see this going is really improving the long-term oral health of our patients. My patients who are in mobile settings, like I have this one patient who just can't brush his teeth and nobody helps him. He attempts to do it. There's nobody really like doing a good job for him. I use it on him and like the first time and I was like, I hope that this helps. And I go see him every 3 months. And compared to that first time, I'm like, it could be that I'm brushing his teeth more often, like encouraging him, my motivational interviewing. It could be a little bit of that. But I also think a little bit of that is the PerioDT, keeping that biofilm low for longer. So I'm really grateful for that for the future to help reduce that inflammatory burden for our patients' overall health. Also, when we instrument, we introduce bacteria into the bloodstream. That bacteria goes all over the place, right? We know that it goes to the brain, we know that it goes to other organs. And so if we can place it procedurally, desiccate that bacteria and biofilm before we introduce it into the bloodstream, like patients with systemic health problems, that's going to make a big difference in their inflammation, right? Also, aerosols. If we place this before we desiccate the biofilm, it's going to reduce the bacteria in our aerosols logically, right? There's been no studies on this, but that's where I'm thinking the future is going. I also use it a little bit off label for aphthous ulcers. If you put it on an aphthous ulcer, put right on, it stings for about 5 to 10 seconds, rinse it off for your patient, cauterizes that tissue. As we know, it cauterizes in the pocket and reduces that necrotic tissue. It creates great relief for your patients. So if they're coming in and they're like, "Don't touch this area, it's so painful," like, you can just I have a syringe in my drawer that's not for a particular patient, but I will get some out in a Dappen dish. I'll and I'll grab it with a little brush and apply it on. So you could do something like that. That's totally off label, so keep that in mind. And then I think something also really important that's going on globally is our antibiotic resistance. And we have a role in dentistry to use less antibiotics. And we've been using antibiotics to treat periodontal diseases over the last many years, locally and potentially systemically. And so this product will help reduce the use of antibiotics and way more efficiently if we could put it everywhere versus just one tiny little spot, right? Obviously, there might still be a place for those. But if we can reduce our overall antibiotic use in dentistry by using other medicaments that are more effective and more powerful, then yeah, this makes sense for a practice, right? Essentially, that's where I see the future of PerioDT.
I love it. I hope get to live really old so I can see all these amazing things happen for our dental world and our patients. I want
I
to see
agree.
all the cool stuff.
I agree. My goal is to live to 100. So if anybody wants to live to 100 with me, I think we're going to see some amazing things in dentistry.
I'm in. I won't be scaling at 100, but I will be watching still. And
I might. Excuse me.
You never know.
One day a week. One day a week.
Like,
Shelley, it is always such a pleasure having you on our podcast. Before we sign off here, can you just tell us how listeners can learn more? And are there any resources, trainings, or support available for dental professionals looking to adopt PerioDT?
Yes, Young Innovation on their website, they have a lot of videos. I know that we're talking here today and you're like, I need to see it. I need to see it in action. So you can go see some of their videos that are on there. They also have handouts for you and more CE that you can also learn a little bit more about how this works and if it's right for your practice, which I really hope that it is because it has really changed mine.
I can't wait to help implement this and get this in the hands of a lot of my providers. So this is exciting. Shelley, thanks again for joining us today. I hope you have a wonderful day.
Thank you.